Hey everyone, today I'll share the information about the runner syndrome. In runner syndrome, anterior knee pain occurs, and there are a lot of causes about the anterior knee pain. One of them is the patellofemoral pain syndrome and pes and bursitis. And regarding the patellofemoral pain syndrome, if you do a Google search, some of them they actually mention that the patellofemoral pain syndrome and the runner's knee they are same. But according to our textbook, these two are not the same entities; they are the different entities. Next, we will look at the patellofemoral pain syndrome. In patellofemoral pain syndrome, there occurs maltracking of the patellofemoral joint. And what does that mean? Before that, we will look at the normal. What is normal? Normally, the patella articulates with the distal femur trochlear groove. While doing flexion and extension, this patella remains in the trochlear groove. But in case of maltracking, this patella comes out. It shifts laterally on extension, but it moves in while doing flexion. It moves to its native site while doing flexion. Now, when in extension, when it is out, there creates a contact stress between the patella and the lateral aspect of the trochlear groove. Because of that, there occurs inflammation, there occurs pain, and there occurs swelling and pain, and that is the patellofemoral pain syndrome. Now, one thing I want to share with you that runner syndrome is also known as iliotibial band syndrome. So don't confuse. Runner's knee or runner syndrome actually is a synonym for iliotibial band syndrome. And these are common in the joggers, marathon runners, and some cyclists or those who are involved in the activities like sports training. And these are also common. And these people also suffer from the pes and bursitis as well. Regarding the pes and bursitis, first of all, we should know about the pes and It is a conjoined tendon made up of semimembranosus gracilis and the semitendinosus, and this get attached on the medial aspect of the proximal tibia. Now this pes and these three groups of tendon actually they are separated from each other by means of the bursa, and they are separated from the underlying bone by means of bursa. And this bursa is the main part which undergoes inflammation or microtrauma in case of like runners. Runners, those who are overdoing it, doing it, they actually undergoes microtrauma, and there occur the pain and swelling, inflammation in the this bursa, and this tenderness and swelling actually specifically at medial aspect of the proximal tibia and occurring in the range of up to 6 centimeters. And if you talk specifically, this pain is over the posterior medial aspect. That is the main insertion point of these conjoint tendons. Now, regarding the investigations in case of pes and serin, all the investigation like USG, X-ray, they are not useful. Only the MRI which is useful here because there occur the multiloculated fluid collection in the posterior medial aspect of the knee. Now, let's look at the specific points where the pain occurs. In case of PFPS, we know it is the anterior knee pain, totally anterior aspect. And if you look at the pes and serin, it is the posterior medial aspect of the proximal tibia. And if you look at the iliotibial band syndrome, which is a synonym for the runner syndrome, here the pain actually occurs at the lateral femoral condyle, specifically at the lateral femoral condyle. And there is one more condition known as jumper's knee. And in jumper's knee, the point of tenderness is at the inferior pole of patella, or we can say that where the patella tendon actually inserted over the tibial tuberosity, that is the main sign. Now let's talk about the iliotibial band syndrome. Before that, we'll look at the anatomy of the iliotibial band. Iliotibial band, it is actually a longitudinal thickening of the tensor fascial artery. Its origin is from the iliac tubercle of the iliac crest, and it gets inserted onto the Gerdy's tubercle of the proximal tibia. lateral aspect, or we can say that lateral plateau of the proximal tibia. No, regarding the functions, it is involved in the extension of the hip, abduction of the hip, and the lateral rotation of the hip. And this track also send some slips, some fibrous slips into the thigh towards the femur, creating the intermuscular septum as well. Now, why this Illiotibial band syndrome? What happens actually here? Due to overuse, there occurs friction between the band and the lateral epicondyle of the distal femur. Now, because of these to and fro movements of the band over the lateral femoral condyle, there occur microtrauma to the band as well as to the femoral condyle. Because of that, there occur inflammation in the band as well as the femoral condyle, and the femoral condyle there occur osseous edema as well. And if it progresses, then it will lead to synovitis. It will ultimately ends up in the synovitis. Now, regarding this contact friction and the contact stress which is occurring over it, it is actually greatest at the 20 to 30 degree of knee flexion. In the 20 to 30 degree of knee flexion, this band is actually excessively tight or stress. And we have a clinical implication of this also. Like in case of downhill running, there occur reduction in the knee angle. So knee angle will reach to around 20 to 30 degree. So there will be aggravation of the pain. Whereas in case of sprinting, fast running, in such cases flexion angle that will increase and the pain will reduce. So we should advise them, do not go for the downhill running, go for the sprint running and on a flat area running. Now, regarding the risk factor, there are a hell lot of risk factors responsible for this runner syndrome. One is the sudden change in the training intensity, and one is the poor shoe support. Poor shoe support, actually, what kind of shoe you should use, and after how much time you should like replace it. Now, that is also important if you want to avoid the runner syndrome. And there are a lot of anatomical factors which are responsible for the runner's knee. That includes one is the genu recurvatum or genu verum, and one is the limb length discrepancy, and excessive foot pronation, and the weak hip abductors. And if the band, the iliotibial band, is too tight, that's also responsible. That's also anatomical risk factor. There are biomechanical factors also. One is the disparity between the quadriceps and the hamstring muscle strengthening. If the one is not doing the strengthening well, then he can suffer from this. And while doing heel strike, if there is an increase in the angle of knee flexion, that is also a factor for the iliotibial band friction syndrome. Now, regarding the clinical pictures, examination finding, if you look at these people, they presented to us with the knee pain, and that knee pain actually relieved with the rest that we all know. And regarding the examination finding, we find out that there occur joint crepitus, there occur swelling, there occur tenderness over the femoral condyle. And regarding the joint crepitus, it is actually at a 30-degree flexion of the posterior border of the iliotibial band. 30-degree flexion of posterior border of iliotibial band. There occur reduction in the hip or knee flexion as well, and the hip abduction movement they also become weak. And if you want to reproduce the pain of the iliotibial band syndrome, which can be done by means of which can also be done by means of single leg raise test. Single leg raise test. And there are provocative tests are there. One of them is Ober, second one is Noble, third one is Thomas, and then the fourth one is Rene Creek test. So regarding the Ober test, in Ober test, the lateral position is given and the symptomatic side kept up and the knee flexed to 90 degree. And then the hip is brought from the flexion and abduction into the adduction and extension. And the test will become positive if there occur pain and tightness or we feel the clicking over the iliotibial band, then the Ober test is positive. Now regarding the Noble test, knee is flexed to the 90 degree. We can see in the picture knee is flexed up to 90 degree and the lateral femur, lateral condyle of the aspect of the distal femur is pressed. There occur tenderness. In Thomas test, you can see the picture. We have the person is not able to do the 90-degree flexion when the affected limb hangs out of the table. And investigation does not have any specific role over here. And the treatment for this is rest, ice pack application, NSAIDs, and followed by corticosteroid injections. And in these people, when the pain and swelling they reduced, these should be followed by physical therapy and the training modifications. And these people actually should change the shoe after 300 to 500 miles usage, and they should go for the strengthening and the stretching of the abductors as well. Now, in these cases, in these runner syndrome, some of the people they actually develop the cyst, kind of a bursa, or they have fluid collection in the lateral recess. And these bursa cysts and recess they should be removed by operative means, and we can do it by means of open approach or we can do by arthroscopically. And those who are suffering from chronic conditions because of non-operative failure, in such cases, we can go for the elliptical surgical incision and we can remove a part of a band tissue. And approximately it should be 2 by 4 centimeter of that band tissue, and that will actually help. And in case of refractory cases, we should go for the Z-plasty, and that is done in the proximal aspect of the iliotibial band. Thank you.